First up, we have Brett Crist. The name of the session is Case-Based Discussions, Decision-Making, and Post-Op Complications. This is another complication section, Ben. First up is Brett Crist.
Yeah.
Osteotomies, fragment mobilization, technical pearls for each cut.
Okay. Thanks again for allowing me to help out. So the learning objectives are to recognize positioning that helps, utilize techniques that facilitates the osteotomy completion, and then fragment mobilization. So I think the first thing is that you do need special instruments. Dr. Matta talked about the special osteotomes that he has for going lateral to rectus. I think you do need special instrumentation sets. I think it just makes it easier. And then the second pearl is set up, so easy visualization to your monitors. You have your techs that are close to you to move things around and get the instruments where you need it to be. I think when you work with a new tech, the hardest thing is for them to get all the osteotomes set up correctly in order. So take time to do that with them if you are working with somebody new. And then I know that we've seen some bikini type incisions. I still do an extended Hooter, which is a bigger incision, but I think especially as you're starting out, bigger is a little bit easier to work with. The ASIS osteotomy, there's two different ways you can do it. I'm not sure who does a step cut osteotomy for the ASIS. So folks that have trained with Keith Stover, what do you do? Block. Yeah, block. So I think you either do the step cut, no osteotomy, so soft tissue release, or Rob talked about just a sleeve. For me, I think just a single block cut makes it, at least for me, it's been easier. So I use, I think using a cordless saw has been something that's been nice for me compared to just another cord on the field that gets in your way. And then just get up to that medial cortex. I complete it with an osteotome and then mobilize the fragment with the soft tissues with elevator. Then kind of work on just mobilizing more anteriorly to get to the pubic ramus, as well as being able to access if you're going medial to the rectus, which I continue to do. Maybe I'll rethink lateral to the rectus. And then the ischial cut, I like to actually use the curved osteotome rather than the angled one. And I usually try to base it on the size of the patient as far as using the smaller versus the larger one. I think using a single cut and not doing multiple cuts with different planes makes it easier to make sure you get the osteotomy complete, as well as like what Joel talked about. For me, it's usually the ischial cut that's the problem as far as not being able to mobilize the fragment as much. And so I think it's critical to try to make sure that you don't make a bunch of planes in the ischium, but try to get a good single cut above the ischial tuberosity. And still go medial and lateral. It is important to obviously protect the sciatic nerve, so either going lateral to the rectus or abduct and internally rotate the leg to try to get the sciatic nerve out of the way. And then, avoid just following the capsule down the ischial, the iliopsoas bursa, and then verify that positioning fluoroscopically with the scissors just to make sure you're in the right position. And then you can we talked a little bit about like if the cut extends into the posterior column, like fixing that, but like you can tell in most patients, unless there's some poor bone quality issue, when you're getting close to that posterior cortex. And you obviously want to make sure that you can get to an angle that you can access it from the internal iliac fossa as well with your ischial cut in that direction. Pubic osteotomy, one of the things that makes it a little bit easier is actually to do a small segment resection instead of like trying to figure out which oblique cut you need to do depending on the type of rotation that you're doing, and using a pencil tip burr to kind of get through the cortex initially for both cuts. And this is something that I learned from Keith Mayo. And then you can try to keep the posterior cortex as a hinge, so when you do your correction, it'll be less of a distance for the the bony healing and may decrease pubic osteotomy non-unions. But I think when you have a large correction like Rob showed in that last case, I think there is a higher risk of non-union just because of the amount of change in the position of the segment. And so use Crago retractors to protect the soft tissues, as well as it just as another verification that you're in extra-articular, and then using basically the burr to get your cortical points where you're going to decrease the chances of splitting, and then using just the centimeter-wide osteotomes to do both segments. And I do the near one first, just to try to minimally disrupt the retractor more medially. Ilium cut, I think making the target with the burr is good. Going over the brim just to try to help facilitate that ischial cut later is helpful. And just to avoid violating the posterior cortex, and try to make sure that you're making a large enough segment. So these are different ways you can do the cuts. I usually typically go through the osteotomy, the ASIS, and then aim that. I think marking it with the burr and then doing the precision saw, which I think is helpful. Just basically using the specific reverse AVA retractor in the sciatic notch will protect you. And then using the precision saw to get down to basically where your burr mark is, and then completing it with the larger, wider osteotome. And then this is just kind of tying it all together. I think the precision saw is nice because it's just the point or the tip that's cutting rather than oscillating saw that has a larger excursion. And it also allows you to hold the saw while you're cutting it as well to help just add more stability. And then just getting your osteotome in place and then complete your ischial cut. So I use kind of all of these. I think initially the angled one is easier to get around the corner for the posterior column cut. And I think one of the things, I've heard horror stories of people having their osteotomes getting stuck in the ischium. And I think you just have to be patient and don't get greedy and just go, back and forth, just slowly advancing. And if you do get stuck, I usually try to slide another osteotome, straight one behind it, and try to basically create space to get the first one out. But I tend to use fluoro, probably maybe a little bit too much, but using sometimes patients are too small to use the finger osteotome, and so straight ones can be helpful too. And then doing the lateral cut with the angled osteotome and making sure your Schanz pins are in place. I really like using the biplanar Schanz pins for correction. I think it helps in all planes, versus I've not used the 3D planning software and the cutting jigs, but maybe in the future. So fragment mobilization using the large lamina spreader as you're doing your posterior column cut can be helpful in helping it basically find its way down to your initial ischial cut. So this is just showing that fragment mobilization, and then that gets you set up basically for your mobilization and temporary fixation. And you can see it just as you kind of keep spreading the lamina spreader and doing the ischial cut, things just kind of continue to open up. And then another trick from Keith is using this angled osteotome to help. You can turn the angled osteotome as you're doing your posterior lateral cut to medialize the segment, in addition to using the Schanz pins. And I found that to be very helpful. So the take-homes, I think using special instruments is helpful. Choosing whichever exposure you feel gives you the best access for you. And then using the specific osteotomes that help facilitate the cuts that you need to make and the size of the patient. I think the most frustrating thing early on is the ischial cut, to make sure that you get that complete. And if it's not moving, that's, at least for me, that's been the problem, not so much the pubic cut. And then utilizing the Schanz pins has been really helpful. Thanks.